Fetal surgery. Fetal surgery is performed while the baby is still in utero. It's for fetal anomalies that cause harm to the fetus and the fetal lungs are not yet mature enough for delivery, or where postnatal surgery success is less likely. Intrauterine transfusion is where red blood cells from a donor are transfused into the fetus. This was first done in 1963 by Dr. William Lilly. In 1981, the procedure was perfected by the transfusion going directly into the vein of the umbilical cord. It can also be done by the transfusion being inserted into the fetus's abdomen. This is done when the fetus is anemic. Fetoscopic laser surgery is performed on twin-to-twin transfusion syndrome. A fetus is inserted through a small incision in the mother's abdomen into the amniotic cavity to get a better view of the fetuses and of the placenta. Abnormal blood vessel connections on the placenta between the babies are then located. Inside the uterus, laser fibre is inserted through the fetoscope and the placenta vessels that cause the twin-to-twin transfusion syndrome are coagulated under direct vision. Laser ablation stops the abnormal fluid exchanges between the twins to halt and then hopefully reverse the disease. After the laser procedure is completed, often an amnioreduction is performed to remove any excess amniotic fluid. Fetoscopic surgery. A fetoscope is inserted through a small incision into the mother's abdomen into the amniotic cavity to provide a telescopic view into the uterus and to take fetal blood and tissue samples. These samples can be used to diagnose a range of things, including fetal abnormalities and neurotube defects. Using the working channel of the fetoscope, some of these abnormalities are able to be treated. These can be amniotic band syndrome and spina bifida. Occasionally, the amniotic fluid is not clear enough for adequate visualization. In these cases, amniotic fluid exchange is performed by using warm crystalloid solution to provide a clear operative view. Open fetal surgery. An incision is made into the mother's lower abdomen, like a cesarean, to expose the uterus. The uterus is kept open with special stapling device to prevent bleeding, and specialized uterine staples are used to fix the membranes to the uterine opening, preventing membrane separation. Warm fluids are continually infused into the amniotic sac to replace any lost amniotic fluid. Once the surgery on the fetus is complete and the uterus and amniotic sac are stitched back up. Ex utero intrapartum treatment, also known as the exit procedure, is used for babies who will have an immediate critical problem once delivered and who will be unable to breathe or transition safely from fetal life. It gives time needed to intervene surgically and stabilize the baby before the umbilical cord is cut. The baby continues to receive oxygen and nutrients while the surgical team performs any procedures the baby needs to survive outside the womb. Exit to airway is performed if the baby won't be able to breathe independently. The fetal surgeon will insert a breathing tube through the baby's mouth or, if necessary, perform a tracheotomy and then finish delivering the baby. Exit to ECMO is performed if the baby has a medical condition that prevents them from breathing successfully or if their lungs need more time to develop. ECMO is extracorporeal membrane oxygenation. ECMO is a machine that functions just like the lungs, breathing for the baby until their lungs have matured enough for them to breathe on their own. Exit to resection is performed if the baby has a large life-threatening mass or tumour and can't receive oxygen until it's removed. Then the mass will be surgically removed while the baby is still attached to the placenta. Then they will finish delivering the baby safely. Exit to ventricular pacing. If the baby has a complete anteroventricular block, rescue pacing may be needed. To make the baby's heart pump normally, a pacemaker will be placed on the baby before delivery. This was first done last year. A 36-week fetus who suffered from complete anteroventricular block and cardiac dysfunction received a temporary pacemaker, which stabilized its dangerously low and irregular heartbeat and ensured enough blood flowed from the heart to the rest of its body for delivery, while still attached to its mother via the umbilical cord. The mother's child's body acts as a heart and lung bypass machine for the exit procedures, allowing life-saving fetal interventions while maintaining in utero circulation. The goal of fetal intervention and surgery is to improve the chances of normal fetal development and minimise postnatal morbidity. Fetal surgery should be considered only if there is severe, life-threatening or debilitating anomaly in the fetus as the risk is still considerably high despite there being no known maternal deaths. With the ever-improving prenatal imaging and surgical techniques, fetal intervention and surgery is always advancing. The future brings fetal surgery that will improve the life of the child, not just avoid death. With the advancement of fetal surgery brings with it the research into other forms of fetal intervention, two of the biggest being in utero stem cell therapy and in utero gene therapy. The future is bright and exciting for the development of fetal intervention. Thank you.